All right, so the Puerto Rican Day, where would the group like to start?
Puerto Rican Day Parade, one of the last episodes that Seinfeld has in the series. Not necessarily one of my favorite episodes. There was a lot going on. I guess we can start with, I don't know, there's so many things going on with every character. It was, for somebody that watches Seinfeld on a consistent basis, to see that the characters were using their regular alter ego names was the funny part for me. The Varnson and the Vandelay and Pennypacker. It's interesting. In terms of psychiatry and how this episode relates to psychiatry, I guess if we can talk about start with Kramer. Thought Kramer was interesting, and Elaine were particularly interesting in this episode. Okay, let's do Elaine, actually. I liked Elaine in this episode. She was tired of hanging out with the boys again, tired of them. She's always trying to leave the group and do her own thing, and then always eventually works her way back to them because she's part of them and they're part of her. And she was trying to leave the immediate environment and took all these people with her to try to escape the traffic and the congestion of the Puerto Rican Day Parade to get home. And now she's Sojourner Truth leading a group of people underneath a set of bleachers to try to get them out of Harriet Tubman, not Sojourner Truth, Harriet Tubman, trying to lead them through underneath the bleachers to try to get them to freedom from the parade, and she just ultimately is not successful. And conveniently, by the end of the episode, she's back to the group. So I think with her, in terms of a psychiatric aspect, she's somebody that I think is a little dramatic, always dramatic, a little histrionic on her part, but doesn't fully understand that they're part of her in terms of the other characters, and she's part of them. Yeah, that's what I have to say about Elaine.
Okay, so we went through a lot here, so let's break this down.
Okay.
One, actually, I was taken by your initial observation or question where to start. Very quickly, in my mind, very strong parallel to psychiatry and psychology, right? So here we are trying to discuss and interpret an episode of a situational comedy, and it parallels wonderfully with about 99% of the patients we see. So where do we start? The patient's stories are quote unquote all over the place, much like a script of an episode. And as a clinician, you have to choose where you'd like to start. So I don't have anything further to say on that, only in that, again, art imitates life. So in your respective careers, get ready for that. Now, for specific scenarios, there are certain algorithms that we try to impress upon people. I think by far the best example would be the individual who comes in with multiple complaints that really appear to be unsubstantiated. And they are usually directed away from the psychiatrist initially, so maybe a neurologist or perhaps a general practitioner. And the referral is made because they can't make any sense about anything the patient's saying, difficulty seeing, blurred vision, multiple somatic complaints for which there does not appear to be an underlying physical cause, right? My medical student goes and sees this patient now upon referral, and they have the same exact, I think, initial impression that you had in trying to express where to start in determining what an episode is about, right? So again, there's that parallel. I'm not going to get into the algorithm or the treatment tree, the decision tree of how to break down what is called a somatic symptom disorder. We've actually done that in this class before. And certainly while you're here, we're likely to do it again clinically. But I just bring it up as an easy example of very, very complex situations that when we have built-in algorithms, decision trees, make the most complex thing. simplified, so that we do have an idea of therefore where to start, right? Just put one example. I also like your observation of their quote unquote alter egos. And I think that this allows us to at least briefly look into a set of disorders called the dissociative disorders, because sometimes when we use a clinical term, we may not be completely clear as to what it is we're directing our attention to. So first, there are 3 disorders that are published in the American Psychiatric Association's DSM within that or inside that dissociative disorders chapter. What are the 3 dissociative disorders published highlighted by the APA? So fugue is not one of them. Fugue is going to be a specifier of one of them.
Dissociative identity.
That's number 1, right? Dissociative identity disorder, or DID.
Derealization disorder.
Depersonalization, derealization disorder. Dissociative amnesia, for which there's a specifier called.
You.
All right, so let's arbitrarily, no, I think this does kind of bear out in clinical practice. The mildest form is usually going to be depersonalization, derealization disorder, the condition that is literally defined through recurrent episodes of depersonalization and or derealization, right? So that brings us right to the question, well, okay, you're using big terms. So what is depersonalization and what is derealization?
Well, I guess depersonalization is when you feel disconnected, the patient feels disconnected from their body, like it's a third person type situation. And derealization is the person is dissociated from their surroundings. They feel like they're not necessarily present in that particular setting.
Exactly right. Okay. And when recurrent and when it lends to some kind of functional impairment, then we could also use the word disorder, and therefore we have depersonalization, derealization disorder, right? So if you've ever had an out-of-body experience, depersonalization, if you've ever had wicked deja vu, derealization, but it's never impacted you functionally, all right, you've had episodes of depersonalization and or derealization, and that's it. However, if it's recurrent and does impact your function, results in clinically significant distress or impairment in functioning, then you have depersonalization, derealization disorder, right? And it's, again, along the continuum of dissociative disorders, it's considered to be the mildest. The intermediate is going to be dissociative amnesia. Usually in individuals who have experienced depersonalization and or derealization, individuals can also have significant gaps in memory that are not due to any physical cause. So there's no TBI, there's no transient global amnesia, or any other physical or neurological etiologies that would explain their amnesia, their gaps in memory. That's dissociative amnesia. I don't have the exact incidence, but there is a subset of individuals with dissociative amnesia who will also travel away from their place of residence usually and assume a different identity, right? So this guy ends up in Tennessee, and he's not a physician, but he's a mechanic, and he's not named Anthony, he's named Bill. That's dissociative amnesia with fugue, the fugue state. Now, the reason why I want to bring this up, especially that fugue state, is because I want to differentiate and make sure we're all clear on what it means to establish a different identity. Even though I now call myself Bill, and I somehow have found my way under the hood and know what I'm doing, which in reality is not true. I'm a mechanic. The fact of the matter is that I do not have a distinct personality state that takes over my conscious awareness. I'm fully connected, right? And that allows me to say that it's associative amnesia with fugue, and it's not DID. Because once I have another distinct personality state take over my conscious awareness.
Mhm.
Sure, that's going to result in dissociative amnesia too.
Mhm.
But that added quality allows me to say that it's DID. This isn't someone who's fully integrated and just assumes a different identity. This is someone instead that is not integrated, as evidenced by a distinct personality state taking over the conscious awareness.
I just need to clarify, because I'm a little all over the place. So are both of them are unconscious? Or are both of them are unconscious?
Yes, yes.
And DID assumes a new personality, whereas amnesia does not assume a new personality. Is that what you're
Right.
saying in simplistic? Okay.
Yeah, doesn't assume a new personality, but otherwise assumes a new identity
Right.
of my personality, of my integrated personality. So a little bit of a difference, and I want to make sure we kind of reviewed that when you said alter ego, because alter ego can mean either, right? Alter ego is more of a social term. Does alter ego actually mean a distinct personality state that takes over one's awareness? Because if the answer is yes, we're talking DID. If the answer is no, it's no. When I say alter ego, I mean no. It's just an assumption of a new identity.
Mhm.
And it's a little bit of a misnomer, right? Because the DSM does define dissociative amnesia, taking over a new identity, using the I word, which becomes part of the definition of DID2, dissociative identity disorder. So that's why there's confusion, and maybe the EPA should look into just relabeling this. Right? If you're going to continue to say that dissociative amnesia with fugue is, and specifically that fugue state is assuming a different identity, then don't use the word identity in DID. Say dissociative personality disorder. That makes much more sense and it lends to less confusion.
So in terms of like etiology, do these disorders present outside of the context of just like trauma? Like, are there other?
I'm sure the answer is yes. I'm sure they could, but by far, the majority result from trauma, right? Especially if you look at DID, then we could work down, right? Intermediate then to mild. The most severe form, DID, the individual will actually break, and even dissociative amnesia, as we discuss this and kind of tease this out. Individuals who are in situations that are dangerous will have their hypothalamus kick in, right? Their fear response kick in. There's fight, there's flight, there's freeze. All right. If you fight or if you flee, then you're not going to have to go to choice C. And therefore you are incredibly low risk for developing a future mental disorder, such as one within the dissociative disorders chapter. However, if you go to choice C because you can't fight, they're much bigger than you are, and you can't flee, they've got you.
So a little bit of your rituals here for you.
Yep. You go to choice C, you dissociate, you freeze, right? And what becomes your functional way of dealing with the fact that your uncle is in your bedroom at 2 o'clock in the morning and he's on top of you, and you go to a happy place, you go to an altered state of consciousness so that you can endure what's happening with a man that you trusted. That becomes a symptom a year later, a decade later. So it's often the result. Now, that symptom could be a distinct personality state that takes over your conscious awareness, and therefore you could have DID, or it can lend to dissociative states decades later, resulting in dissociative amnesia, with or without fugue. But you could see the fairly linear relationship between that history of childhood trauma and the dissociative disorders, especially dissociative amnesia and DID. Now, the other way, a non-traumatic way, LSD.
Oh,
All right. So if you drop some acid when you were 14 or 15, and now you're 34 or 35, your brain could have irreparable brain damage from that one time.
so if it's substance induced, is that just like a specifier?
Yeah. So there you would even talk about this being hallucinogen induced psychotic disorder. I think that would be the proper name. There used to be such thing as a hallucinogen induced hallucinogen-induced dissociative disorder. But in 2013, the APA recognized that everything that induces dissociation and dissociative states also induces psychosis. So they streamlined it, made it much more simplistic. The neurobiology of dissociation really does merge with the neurobiology of psychosis. So now there's only one kind of encompassing term, and that's substance-induced, including hallucinogen-induced psychotic disorder.
So that can encompass a wide range of like psychotic features, not just.
Correct.
social- okay, got it.
Correct. Yep. All right, so now your third point. So just going through the 3 points you brought up in the beginning of our discussion, Elaine. Couple things here. Number one is I like what you brought up in terms of your observation of her wanting to escape her friends, and then her also being a bit dramatic, because it really does get at the core of what we've talked about now fairly frequently, and that is when somebody presents with concerns of their behavior. I'm feeling this way, I'm doing that, or I've been told that I have to stop doing this. I always want you to train your brain to think, okay, what you're doing is completely normal until it's not, right? So always have an open mind, always have that unconditional positive regard when you're building rapport with your patient in the first seconds of meeting them. Why wouldn't this be situational? Why wouldn't this be something along the lines of a midlife crisis that is directly governed by Elaine being in midlife? And this is what people of her age go through in terms of looking at their friends and thinking, I need more. That's very normal. That's very normal. On the other hand, when we see aspects of Elaine's behavior that will force us to move beyond that starting point, we have to start considering that there might be more to the equation here. And maybe you did use the H word, and this is where I will bring in the idea of her being histrionic and us having to discuss the histrionic personality disorder. If that's the way I would want you to get to this particular personality disorder, always start out thinking it's normal.
Right.
Only when it's not, then we kind of evolve our thought and tease that out, ultimately arriving at a rule out of histrionic personality because of her over dramatic nature. Is it longitudinal? Is it stable over time? Well, I mean, you said this is among the one of the last episodes in the entire series. 8 years prior, it's a 9-year series. 8 years prior, do we see this behavior in Elaine? Yes, we do. So we know that it is persistent over time. It's chronic, and therefore it's consistent with her personality. Just because we use the H word, this is a cluster B personality disorder that does adhere to a cardinal trait. If you just remember that cardinal trait, and then you look at the diagnostic criteria, you won't have to memorize those diagnostic criteria because they'll just in your mind become examples of that cardinal trait. That cardinal trait that it's going to serve you very well to remember is that the individual with this condition must be the center of attention. And when they are not, they endure that situation with extreme anxiety. And just for completeness sake, others, we're actually going to start discussing this at Red Run for next month because we're going to be doing the. Actually, I take it back. I'll talk to you about it later.
Okay.
We have a special personality disorders lecture next
Nice.
Tuesday. Red Rum is delayed 1 week. It's not Red Rum. We'll be discussing personality disorders, among which there are 3 clusters. Cluster B, just for completeness sake, includes 3 other conditions beyond histrionic personality. What are they? Yeah. So for those listening at home, it's narcissistic, borderline, and antisocial personalities, along with histrionic personality, a total of 4 that are cluster B. Yeah, much more to say on that on Tuesday. You on call on Monday?
No,
Okay.
no, thankfully.
This is when residents usually look at me and say, I'm on call on Monday, I'm post call, I won't be there. We have 2 minutes left. Any other observations? Seinfeld's Puerto Rican Day Parade. Okay, so I'm going to leave it here, but I do have one final thought, just to kind of throw it out there. Anybody happen to, discover the link between the assignment of this episode to watch before today and the assignment of our new movie?
You know, to me, it was, I feel like I'm a very simplistic thinker in these classes that we have. The LGBTQ factor, there was, I mean, with Seinfeld.
There's definitely that. Yep.
And the dissociative that you were, I guess, with the characters in the Rocky Horror Picture Show, I guess. Maybe there are some dissociative elements.
I wonder,
with some of the characters.
Fox has never considered making a prequel to that. I would love.
Really? With who? With Funk, the hot dog guy, what's his name? Frankenfurter. Yes.
Hot dog guy.
Frankenfurter. Frankenfurter.
Yeah, yeah. Wow. I mean, it would be on their planet, right? Pretty intense. I can't go down that rabbit hole right now. It's for the weekend. There's even a more simplistic thing. I'm not going to give it away, by the way. And so the didactic that we create is called Seinfeld. So I'll leave it up to you guys to figure out what the connection is between the selected episode this morning and the film we're going to discuss. And we'll leave it there. Do we want to hang on the same link, or you want to log off, log back on for table rounds? How does that work best for these folks?
We could switch. It's okay.
Switch, all right.